in Healthcare Administration and Direct Patient Care, Katherine Mathews is a St. Louis University School of Medicine professor in the Department of Obstetrics, Gynecology, and Women's Health. She also serves as the Director of Education for the Bander Center for Medical Business Ethics. In 2020, she launched an innovative required curriculum for first and second year medical students called Leadership in the Business of Education, today she'll be talking about what is medical business ethics and why does it matter. Thank you, and please welcome Dr. Mathews.
Good morning. Can you hear me okay? Great. Katherine, my pronouns are she, her, hers. I wanted to do 3 things today. I wanted to tell you a story about the Bander Center for Medical Business Ethics, where it comes from. I wanted to tell you in medical education what we mean in this course by ethics. And then I wanted to tell you how we're teaching this curriculum. So the story starts with a physician here from St. Louis named Steve Bander. And Steve Bander is a nephrologist, which means he deals with the kidneys. And what's relevant here, kind of a quick overview of history, is that when people have what we call end-stage renal failure and need dialysis, and ideally get a transplant, but need dialysis, since 1972, for people who qualify, those folks are covered by Medicare. Medicare was created in the 1960s to provide insurance coverage for people based on age, but was extended in 1972 to this form of disability and has been extended since to cover other forms of disability for people who have basically contributed into our system through Social Security. Because Medicare covers dialysis, it became an opportunity for industry and business. And Steve had worked for some dialysis companies in the for-profit sector, so not companies that were technically not-for-profit, but for-profit sector. And these companies kept being bought up by larger and larger companies. And as the companies were being bought up, he ended up working for a company called Gambro. And over time, the decision-making in these companies, as they were merged and acquired by larger companies, the decision-making around patient care became more and more intentionally focused on how do we make money. And Steve, being a physician with a duty to do no harm and a duty to care for patients, worked on this for a long time, tried to counter these policies where people were getting unnecessary testing or being given unnecessary medications, and he wasn't getting anywhere, and he was eventually fired. Well, Steve is a super smart guy, and he had kept track of all these policies and what was documented and where the documentation was. And in April of 2001, he got a legal team together and did what's called a Medicare whistleblow, basically alerted the government that this company, Gambro, was systematically defrauding both Medicare and then Medicaid, which provides coverage for people based on income, systematically defrauding the federal government by doing unnecessary testing and providing unnecessary medications. At the time, this was the largest fraud settlement ever in Missouri and the 6th largest ever in the United States in terms of Medicare fraud. And as part of the whistleblower legislation, Steve got a payout. So Gambro had to pay $350 million in civil and criminal fines to the federal government, and Steve got a portion of that. Well, Steve really, had been through something incredibly difficult, incredibly challenging, and part of what was driving his concerns after this whistleblow was basically, they don't teach you this stuff in medical school. They don't prepare you to deal with these kinds of situations. And so Steve used part of that payout from the federal government to create the Bander Center for Medical Business Ethics, and he funds activities both at SLU and at WashU under Jim Dubois. Well, Steve had an agenda then for a long time that we would figure out how to do more systematic teaching and preparation of medical students so that they wouldn't get caught off guard. And basically, as we talked and as the Bander Center has developed, it came down to two core things. One, helping medical students understand that money makes the world go round, that money drives decision-making, it drives how healthcare operates. And even though we complain about the costs of spending on healthcare in this country, every dollar spent, to quote Uwe Reinhardt, formerly, who passed away recently, a professor at Princeton, every dollar spent is somebody else's dollar of revenue or profit. So it's a fairly entrenched system because many, many people benefit from it. So on one hand, helping students understand how money drives our behavior, and on the other, what he called a practical ethics. How do we help students be prepared to deal with things where their gut tells them there's something not right going on here? My own background, in contrast to Steve, and this is an addendum to the Steve Bander story, had been completely in the not-for-profit sector. So I have always worked in what's called safety net care, where we provide care for low-income populations, medically underserved populations. So often I've provided care for people with absolutely no insurance at all, or people who have low enough income to qualify for Medicaid, which in this state in many ways has been very difficult. In the not-for-profit sector, I had also run into issues where I saw money driving decision-making in a way that wasn't appropriate for patient care. And so I brought my own set of concerns around this as well. And in fact, I had had a leadership role about 10 plus years ago. I was a chief medical officer and got an MBA just so I could grapple with the financial side of medicine. And then the other thing that I brought to this experience is that I currently serve on the state board that licenses and disciplines physicians. And although it's highly unusual to have a really bad actor, there are physicians and other healthcare professionals who do things that are really harmful, whether it's financial or violating boundaries, inappropriate relationships with patients in a variety of ways. So I was also aware that as a profession, we still have a lot we need to do in terms of preparing medical students, helping educate medical students, helping bring more moral humility into the medical education process, and also to have more of a process where we can identify folks who are potentially dangerous before they get out to practice. So that's the story part. The second part is, what do we mean by ethics? And I know this is something you all think about all the time. In medical education, it's a little challenging because medical students are really good at certain things. They are really good at memorizing facts. They are really good at absorbing huge amounts of information and mastering complex systems and taking tests on what they've learned. They're really good at taking tests where there's always a right answer. So if it's A, B, C, D, or E, one of those answers is always right, and there's always one right answer. And we also teach traditional healthcare ethics at SLU, as many medical schools do, which teaches a set of principles and guidelines for making tough decisions where maybe a patient wants something and family members aren't in agreement, or maybe it's an end-of-life issue and it's a case of what we consider futility, where there's nothing more that we can do. So they're also taught healthcare ethics in a way where, in fact, they have to take tests on it. And in the national exams that medical students take as part of the licensing process, even healthcare ethics is taught in a way that there is always a single right answer and there's always a right answer. Well, the material we wanted to bring forth was much more muddy and confusing, because sometimes in situations where you have this gut that I'm not sure that this is okay, I'm not sure that people are doing the right thing, it can be very unclear about what the right answer is, and there may be situations in where there's no one clear right answer. And so for me, the background I brought was partly my own faith tradition, which is Protestant Christianity, and the awareness, as you all say, that we are all human. And in my understanding, as humans, we're kind of stuck with the fact that we're going to make mistakes and we're going to cause harm. And as much as we want to get all the answers on the test right, as much as we want to memorize and know the right thing, that if we teach medical business ethics as a set of right answers, it's going to be like handing someone the booklet with the laws about how to drive in Missouri, and then, you know, to my 17 or 16-year-old saying, here are the car keys, you memorize the rules, go ahead and drive. So the other issue for medical students, we spend a lot of time helping students understand how it is we know what we know in medicine, and so it's really important not just to come to them with opinions about how we might teach this, but to come to them with things that are more research-based. So when we thought about teaching ethics, some of the influences were a writer named Jonathan Haidt. Now, Jonathan Haidt has written a book recently, past couple of years, called The Coddling of the American Mind, but he's also credited with this really interesting image about how we make decisions as humans, and it's called The Elephant and the Rider. And in this image, and if I had slides, I would have a picture of a small person atop an elephant. In this picture, we often think that we're the rider, that we're in control, and that we're the one telling the elephant what to do. But what we know about the neuroscience of decision-making is it's that deeper, more emotional part of the brain that is often driving our decisions. This is how the impact of bias shows up. This is how the impact of blind spots shows up. So spent a lot of time thinking about Jonathan Haidt, and also the students are also introduced to the concept of what we call behavioral economics and a writer named Daniel Kahneman. And Daniel Kahneman speaks about this in a different way. He talks about different systems within the brain. System one is that automatic system where it's Saturday and I start driving the car to go to the grocery store, and the next thing I know I've driven to work because I'm in that automatic process. System two is that more labor-intensive kind of thinking where we have to stop and reflect and learn new things. So bringing together these concepts of how it is we make decisions, how it is that we can have an illusion about being in control when we're not really, and we have biases influencing what we do, how it is that we can help students understand that knowing the right answer or knowing the rules or knowing the law is very important, but it's not enough to safeguard us from bad action. All of this came together to really figure out a way to teach ethics more as moral action and moral decision making. So having come to that, this notion that we were going to try to launch a very different kind of medical education, the question then became, how do we actually figure out the curriculum? So this is the third part about how we're teaching. So in my own experience, as you heard, I've done a lot around public health. I worked for about a decade at WashU, primarily with the Siteman Cancer Center, and I worked on a number of programs both to increase access to care and also to increase participation of people from diverse backgrounds in cancer research. And the way I went about doing that work, we put a fancy term on it called participatory, but it just meant that I went out and actually met with people in the community and got to know what was of concern and what wasn't working well. So this notion of participatory, it also fits with our Jesuit mission at St. Louis University of being people with and for others. I thought, well, if I'm gonna try to teach a very different style, do a very different kind of education in the medical school, the best place for me to start is with the medical students. So in the summer of 2019, we did a survey of all the classes of the medical school. It was optional and anonymous because I didn't want them to feel pressured or as though they had to give me a right answer, because students are really good at, well, what's the right answer I'm supposed to give you? And we asked them, what do you think medical business ethics is? And if we were teaching it, what would you want to learn? So we started out with a survey. I then created, because I luckily had about a year of planning before launching the first year of the curriculum in 2020, I luckily was then able to create an elective where I asked first-year medical students to apply and be a team with me to create this course. And I had 7 students who then joined me to be co-creators of this curriculum. And they helped me do a couple things. One, and I think this is language that you all use, they identified very quickly that we have an explicit mission and value statement that we use for the School of Medicine at SLU, and that this curriculum needed to be grounded in those values. And very specifically, the values that they pulled out were the values of being attentive to the whole person as we provide care, and to be attentive to the contexts in which those people live. And that we also had to be aware of all the things that affect someone's health. And in this way, understanding the economics around healthcare and how money can drive decision-making were super important. The other thing they did was outline that we really needed to think about this course in two ways: what they called a structural bin, where we helped expose students to the structure of the healthcare industry, and a personal bin, where we helped students work on their own awareness of their values. And a lot of this has fallen under the header of what gets talked about a lot in the business community of emotional intelligence. And so understanding those two bins, structural and personal, then flowed into how the course is structured. And it actually, in some ways, has three components. So on the structural side, I do give some lectures, and I assign some readings, and I have students take an accountability quiz just to make sure they've actually looked at the material. And because students are so good at memorization and mastery, I realized really quickly that giving them a high-level understanding of, okay, pharmaceutical industry, device industry, insurance, all those things was going to get really confusing really quickly, because they would want to understand it in detail, and all of this stuff is changing constantly, and especially when it comes to things like insurance coverage and Medicaid, it varies by state. So on the structural side, we've really narrowed down to two things: helping students understand how private insurance, Medicare and Medicaid, pay very differently, and that basically private insurance pays a lot more than Medicare, and Medicare pays more than Medicaid. And so the fact that we get paid different levels for providing care to people with different coverage can really affect how we provide that coverage. And if someone's uninsured, that's even more of a challenge. And on the other hand, the other place where we focus is on how physicians get paid. And so being aware that the incentives that a system sets up, even a not-for-profit Jesuit institution and a Catholic healthcare system, that we're constantly being incentivized based in ways that might drive us to provide certain kinds of care to certain people and not to other kinds. So that became the structural bin. The second piece, and we heard a bit about patients with asthma, was to help students understand what it looks like from the patient perspective to get care by creating a made-up story. We have these made-up families that we use that are meant to at the med school, that are meant to represent people from different parts of St. Louis. So we have a family from Ferguson, and we have a refugee family that originally came from Bosnia, and I created a family that comes from Clayton. And so I picked three family members: a young African-American man, a child whose parents had come from Bosnia, and a cousin. He's made up of a Clayton family who's white. And I gave them all the same asthma, and then I gave them different insurance coverage. So our child who's from a refugee family, eligibility for Medicaid, if you're a child, the thresholds are much higher, so she's covered by Medicaid. This gentleman over here, my white cousin from Clayton, whose made-up name is Philip Mason, he moved here and he was working in the gig economy. He was driving Lyft or Uber and delivering food, and he was in his late 20s, so he's no longer on his parents' plan, so he was uninsured. And then Joel Johnson, my gentleman from Ferguson, he had a full-time job and he was covered by his employer. So they all journey through getting in to be seen for their asthma, trying to see a specialist, and then Philip, unfortunately, gets COVID and ends up with long COVID. So we take the students through this journey of what the coverage is like, what the access is like, the literal places that you get seen in our town based on your insurance coverage. But the final piece, and perhaps the most confusing for the students, is how we run small group. So that's where we do the personal bin. And the whole goal in small group, many times in small group, whether it's high school or college, seminar classes, or even in medical school, is that you get a bunch of people in a room and you have a case and you debate and somebody's right and somebody's wrong and other people are very quiet. I wanted to create a different approach to small group. I wanted to create an opportunity for students to really practice what I think of as the emotional intelligence skill set, and very specifically self-awareness, self-regulation, and empathy. And so the way we launch this is we have students do a values interview. So I'm paired up, if I'm a student, I'm paired up with somebody else in my small group, and I sit down with that person and I ask them, tell me about a value that's important to you. What do you name that value? And then tell me a story that you would be willing for me to share with the rest of our small group about how you know that that is an important value to you. And then we switch roles. And then students come back and they present the values of their colleague. And I was really pleased because in the first year of the course, I was running small group, and so I paired off with one of the students, and her value was, I can learn from anyone. And her story was that when she'd been in about first or second grade, there was a classmate who just, she had really dismissed him because they were reading James and the Giant Peach, and he couldn't read very well, and so she didn't think much of this person. And then someone brought one of those puzzles to school one day, like a Rubik's Cube, and this kid, he could figure out that puzzle like that. And so she was like, oh my goodness, I can learn from anyone. So students identify values with two goals. One, to really reflect on the fact that our deeply held conviction, our deeply held sense of what is right and wrong comes from a very specific place. Also, reflecting on my values, if I'm getting into trouble, if I'm stressed, if I'm overworked, if I'm underslept, and I'm not at my best, I can intentionally practice connecting to my values for figuring out what I'm going to do in a situation, or even if I just need to step away and take a deep breath. But the other goal of this was to help students learn that as much as I believe in my values and my sense of right and wrong, other people come from different places, and there's integrity to those points of view. Other people have things they believe very strongly, and it's because of their lived experiences. And so the idea is to begin to create an openness to a diversity of points of view around an issue. And then with that being the leading small group activity, we go from there, and again using the asthma flare, to create situations that are meant to bring forth different opinions, like should pharmaceutical companies be able to make a profit off of the vaccine. So they're meant to bring forth different opinions, but not in a way that students will debate, but where they will practice listening to each other. They will practice, if someone comes forward with a point of view that they find unsettling, instead of just arguing against, they practice going, can you help me understand more about that? And I watched one student last year in one of my small groups. Someone said something very blunt, very strong, and I felt a reaction in the room, and a student to my left turned to this person and said, I invite you to help us understand where that attitude comes from for you. And as we listened, we learned a whole lot more about this person and the experience that she had had. So that's this very tricky thing. They go, wait, we're just talking to each other? Wait, we're just practicing listening to each other? But that's how we're working on that part of the curriculum. The final piece, because this is it's a curriculum that runs through their first year and a half before they start moving into the clinic and the hospital, they have a final assignment, and I came across this last summer, so I'd been teaching the course for a year and was delighted to find Brené Brown's book, Dare to Lead. Now, Brené Brown is really well known for her work on the importance of vulnerability. And very specifically in this book, she talks about, if we think about courageous leadership, there's no courage without vulnerability, because courage takes emotional risk. And so Brené Brown also talks about values, and she has an exercise in the book, which I have this second-year students doing this year. I've done myself and invite you all to think about, and I know you think about these things a lot, is for me to pick my two most important values Brene Brown says that with lots of research they've done on leadership, most people have 2 core values from which everything else flows. And then to name 3 behaviors that demonstrate that I am acting in accordance with those values. So 3 for each. And then 3 behaviors that she calls slippery behaviors, or what we talk about with the students, risk zones. What is a signal to me that I'm not at my best? What is a signal to me that I'm at risk of acting in violation of my own values? And so that's how we wrap this up. There's so much more to do with this curriculum, and one of the ways that I continue to work with students is to do regular feedback surveys, find out what's working, what's confusing, what they want to learn more about. And so this curriculum is still in development. And as you heard at the beginning, because students think that ethics is really about a list of rules, and we're teaching in this very different way, we have, with their help, renamed it Leadership in the Business of Medicine. But I invite questions from you all when we do Q&A at the end to hear your thoughts and your ideas and anything that you would add as we think about ways to really create a group of leaders who are not just there to care for individual patients, but to make sure that the healthcare system reflects the values that we would have for it. And I thank you for your time.
Thank you. We are not passing collection baskets right now, but if you're moved to make a donation today, you can do so at ethicalstl.org/donate. But don't feel that you have to. We recognize that this is a difficult time financially for many people. I have a couple of announcements. There will be an opportunity to buy ethical yard signs today. We are asking for a $10 donation. Meet with Laura in the back after platform if you would like one. I also have an announcement from James that Good Cheer will be December 12th at 10 a.m. in this auditorium, and that the society is closed both on December 19th and December 26th. So please make notes in your calendar so that you show up at the right time and don't show up at the right time. We will now have our final musical selection from Tom Burr.